Thanks, Rod. Thanks, everyone. Thanks for having me today. So you see in my bio, I am from the University of Notre Dame. I do two positions. In the other position, I'm a communicable disease epidemiologist at the WA Department of Health. So my focus for this talk today is primarily going to be on the work that we've been doing at DOH around vaccine effectiveness and vaccine safety. So just before we start, I'd like to acknowledge that we are meeting on Wajak Noongar Budja. For anyone who's come interstate, we've treated you to a bit of cold weather this week, so I hope you've enjoyed it. I've had a few people ask me or say to me they didn't think it really got cold or wet in Perth, but I can assure you it does, so welcome. Today I have a few things, sorry, I'm struggling a bit because I can't see my slides. So the purpose of my talk today, so I've really got two sort of key overarching things. I've tried to build my talk in mind that I'm hoping we've got some general practitioners, some immunisation providers or people who interact, I guess, with the public and deliver immunisations in the group. So what we want to get out of this today is to understand the vaccine safety monitoring systems that are in place for adult vaccinations in Western Australia and more broadly across the country, thinking about the reporting requirements, so those statutory reporting requirements that we all have to report vaccine adverse events, and to review the process for evaluating the effectiveness of vaccines. So I was it was good to see Katie's talk this morning, and I guess in those key issues of vaccine safety and effectiveness, they are at the sort of the forefront of people's minds. So I think this is really sort of timely and important information. I don't have enough time to get into it today, and I will say I'm a meagre epidemiologist, so I spend a lot of my time crunching numbers and I suppose not a lot of time in the social side of things. I think I will acknowledge, and anyone who went to the conference and heard Eve speak, the idea that we can sort of fight some of these things just with data alone is probably not going to be enough. So I think what we can do with this is support immunisation providers with data that they can share and discuss with patients, but I do acknowledge I think it's only one half of the picture. So thinking today how vaccine safety is monitored in WA and sort of nationally, and particularly focusing on how we're now using data linkage to improve vaccine safety monitoring. So out of the COVID pandemic, there has been a lot of work and a lot of additional sort of resources put into it, and we've actually been able to use that to link a lot of our data collections together, which I think has really improved these systems, and also thinking about how we assess the effectiveness of vaccines. So the first part of the talk I'm going to focus on is on vaccine safety. So I do apologise for anyone who is familiar with these things, but I do like to sort of define the terms first. So when I'm talking about an adverse event following immunisation, it could be due to a person's response to a vaccine. It could be conditions that occur following the incorrect handling or administration of a vaccine, so it could be related to a vaccine error. Or it could be a total coincidence, so it could have just occurred proximally to the vaccine, and what we're trying to do is sort of capture all these events and try and work out what is happening and to see if something is truly related to a vaccine and if there is any sort of safety signals. Any event felt to be significant following immunisation should be reported, as well as a vaccine error. So for those who are responsible for reporting these, any of these things do need to be reported, and then we can go forward from there. Importantly, because I do get this question a fair bit, it's not required that people report sort of those minor and common and expected events in terms of the statutory requirements for reporting. They don't need to be reported. Of course, they can be reported if people would like to. And I think this is a key point that sometimes is missed. Any reaction which you feel has affected the confidence of the vaccinee or the family in terms of future immunisations can and should be reported. So just because the event in and of itself may not be considered to be a serious adverse event, if you feel like it has impacted vaccine confidence, reporting that and allowing the system to work with those families can be really beneficial. Who can report? So any vaccinated person, so anyone in this room, the parents, guardians, immunisation providers or treating medical practitioners. So I will note in this, I've talked about WAVs a lot in this system. I am from WA, that is our vaccine safety reporting system, but anywhere you are working there will be a reporting system within your state or territory to do so. So on that, just a very quick legal on the statutory requirements. So above and beyond what we were sort of saying you should be reporting or you should feel comfortable reporting, within Western Australia particularly, medical and nurse practitioners do have a statutory responsibility to report these vaccines. So that's encapsulated, as you can see there, in our Public Health Act and our public health regs. So who can report? I mentioned before, immunisation providers, parents and guardians and vaccinated individuals. And just to note, there's a sort of a central system that collects all of these data within WA. and then that is forwarded and reported up to the national system. So we have local systems that feed in, and all the adverse events are monitored sort of centrally to look for signals. So I have a bit of a schematic here, which I'm going to try and click through. So this is how we were monitoring vaccine safety in WA pretty much up to the point of when COVID hit, and then I'm going to look at sort of some of our more advanced systems. I've put these in terms of active and passive surveillance. In defining those, passive surveillance are sort of systems that rely on people reporting into you. You're not seeking out information, you are just relying on that information coming in, whereas active surveillance is where you're sort of going out and actively looking for events and asking questions of people. So what that looks like, so up the top, so we have a patient encounter, so someone receives a vaccine, and looking at the different outcomes that we will be measuring. So someone may have an adverse event, so that could be an administration error, that could be some kind of reaction. We're looking for those. As a result of that, the person may or may not go and seek medical advice, so they may call Health Direct, go to their GP, present to an emergency department, be admitted to hospital. And we're also monitoring for mortality following vaccines. So that's anyone that dies within a certain period of time following immunisation that may need to be reviewed. How those passive surveillance systems work is noted. So either the individual or the medical practitioner can report those down. Our system falls under something called SafeVac, which is the system that us in Victoria use, and that comes into our WAVS system. So this is how we would capture our events most of the time especially for our very serious adverse events, so those events that we think require additional follow-up. In WA as well, we also have active surveillance systems, and in here I'm specifically speaking about SmartVax, which some people in the room may be familiar with. It's used a lot across quite a lot of the states and territories. This runs out of GP practice software, and when someone receives an immunisation, they are sent an SMS at certain intervals after they've received that. So for the COVID vaccines, we did this at 3, 8 and 42 days. As you can imagine, that's to sort of try and capture some of the immediate adverse events, some of the shorter term ones, and potentially some of the longer term ones. So this doesn't run out of all GP practices. It's designed to be sort of a representative sample, and we send the SMSs out. We receive that information back about adverse events that goes into the SmartVax system. Anything that's considered to be a serious adverse event, and particularly ones that were medically attended, so required to see a doctor, will come into the system, and they will be entered into WAVs and then go up through the same sort of pathway. And I think just to note as well, then all of this stuff is going to the TGA, as I mentioned, to the national system. So with that being said, there are potential gaps to this system. There are potential gaps for any surveillance system. And as we were looking at this, I guess some of the key ones that we sort of acknowledge and identify. If for some reason a patient or a medical provider doesn't report that information to WAVS, as I mentioned, it's a passive system. It relies on people logging in and reporting. If people aren't using that system to report the adverse events, don't come to WAVS, they can't go to the TGA. So there's a potential that those events may then be missed. In addition, the SMSs, people may be a bit fatigued of getting lots of SMSs. If they don't respond, if we don't get the information, it doesn't come back in, there's no potential for them to feed back into our system. So with that, I want to spend some time talking about what we've been doing in WA Health in terms of data linkage during the pandemic, and how we've used this really to enhance our vaccine safety reporting systems. Defining some terms first, I'll put my hand up and say I'm not a data linkage person. I'm an analyst, so I deal with all the data once it's been linked together. But just a very brief overview of how data linkage works. So it connects pieces of information that are thought to belong to the same person across different data sets. And what we use in WA Health is what's called probabilistic matching. So very simply, because that's the way that I understand it, there are different pieces of demographic information that are available in all data sets. The data linkage branch uses that to generate sort of this matching score. And then there is a threshold. So when someone has enough pieces of information that match together, it's decided that this record and this record belong to the same person, and they're given a unique linkage key. So most commonly used to analyse and aggregate population or cohort data. And I do want to give a shout out to the WA Data Linkage Branch. They've been doing this since 1995. We do have quite a good history of data linkage within Western Australia, and I think we're really starting to see how useful this is for our sort of operational work. With that being said, so just a very quick overview of the system. So this is giving you an idea of what we were able to link during COVID-19 pandemic. So for the first time, we actually had AIR, the Australian Immunisation Register, data being pulled in, and we've got that from, you can see, the Enterprise Data Warehouse. So that's basically a backbone of almost everybody within our population. There are obviously some caveats of that, people who don't have Medicare cards, people who don't appear on AIR for whatever reason. They're coming in there. We're also getting our vaccine safety data, as I sort of mentioned before, that's linked, so we can see if events have been reported following an immunisation. Into this, we're pulling in a lot of our sort of core hospital data collections. So you can see from there, we have emergency department data, we have the hospital morbidity data collection, so that's admissions data for people who've been admitted to hospital. We have what's called live admissions, so it's a snapshot of people who are currently within the hospital system. And also into that, we can pull in important things like the death registry data, our notifiable disease data, pathology, and particularly, as I'll talk about for vaccine effectiveness, we were able to get positive and negative tests for COVID, which helped us to analyse our vaccines. And all of this comes together, as I mentioned, the data linkage people do their thing, and what we are left with is data sets that have these unique identifiers across them, which we're then able to link together to do some of this work. So the benefits of this, sort of thinking back to the slide about some of the potential sort of missed events, hopefully we can see how this is sort of hoping to fill in some of those potential missed events. So it's not reliant on people reporting to us. We can see when someone has been immunised and follow them through and see if they've had an emergency department presentation, or see if they've had a hospital admission, or see if they're on the mortality register. So it takes out that element of needing for people to report it to us. I think importantly, as we probably picked up on that slide, it is looking at sort of the most serious events that will either result in an ED presentation or in an admission. So we do not have any primary care data in here at the moment, and I'll come back to that. So that's obviously a limitation of the system, but it's really sort of capturing those quite serious adverse events, or what we would consider to be quite serious adverse events. Without an initial clinician review, so all we've got is the fact that you've been vaccinated and then the fact that you've presented to a hospital. So that's a sort of a proximal relationship. Without that initial review, we don't really have any determination or any causality. That then needs to go into a system where it is reviewed, and we determine whether or not an event was potentially related to a vaccine or not. It draws from existing data collections. It probably goes without saying there are a number of limitations if you're using existing data collections. So what you have access to, as I mentioned, is going to be the big one. So if you've only got hospitalisation data, that's all that you can see. And in addition to that, we do have to bear in mind that these data were not collected with the primary objective of assessing vaccine safety. They're just the general set of data, admissions data that we get when people are admitted. So it doesn't collect all the fields that we would like it to collect, but we just have to sort of bear that in mind and use it as best we can. It covers almost the entire state, as I mentioned, which is good, and it's relatively timely. So in terms of some of these data collection systems, I'll talk about them in more detail. The live admissions data, for example, is updated every 3 hours to give you sort of an idea of how quickly you might be able to get information out of it. So I'm going to give a couple of examples now of how I've been using this for vaccine safety. So the first one being case finding, we're sort of determining it. And so what we did is we prospectively linked our COVID-19 vaccinations to ICD-10 codes for particular conditions of interest. So thinking about using our ED data or our admissions data. So I talked about some of the limitations on that. Emergency department data we will get generally within 24 hours, and it might take up to sort of a week to link it. That has a single ICD code that's been given during the presentation. So depending on how good that coding is, or how well we think it's reflective to why that person has presented to ED, being very specific with the codes might miss some conditions of interest. Whereas the admissions data, fantastic, has a primary admissions code, 20 additional diagnostic codes. It will take about 2 or 3 months for all that data to come to us. So thinking about that trade-off there between, as I mentioned, sort of the timeliness of the data and how accurate or how granular it can be. We've looked at this for particular conditions of interest, so it probably won't come as a surprise, most of these that we're looking at. So TTS, particularly following AstraZeneca vaccine. We're looking at myome pericarditis following mRNA vaccines. And what we do is we find cases with associated codes within a certain time of admission. So depending on what the condition is, we might go really far in or sort of really close out. Once we find these, they are sent for clinician review. So as you can probably imagine, this system, there is a bit of a difficulty. You want to make it sensitive enough that it's picking up cases that are of interest, but we can't be sending thousands of cases to our clinicians to review if we don't think there's actually going to be a link. So there is a trade-off there. And if appropriate, we enter that one into WABs for review. And I just got a note there that we end up finding, this is actually outdated data, but a couple of hundred cases of adverse events were found using that system when we last looked. So the other thing that we're looking at is proportional ED presentations. So the proportion of people who presented to ED within a certain time of vaccination. We have validated this using the FluVax 2010 data for anyone who was around during 2010 and remembers we did have a high proportion of admissions, presentations to emergency departments associated with febrile convulsions. So we're wanting to have a look if we were running a system where we're looking at by brand, the number of presentations within a day of vaccination, would we have picked up, I guess, this signal? And this is just some of the preliminary data here. The writing's very small, but you can probably see on that graph which one was the FluVax. So visually, we would have gotten an idea quite early on that there was potentially something that needed closer monitoring for that one. And the last way we're using this for vaccine safety is what's called rapid cycle analysis. We can use this for newly introduced vaccines, and we're comparing signals by looking at observed versus expected results. And we are currently running this for our bivalent COVID vaccines. I'm going to, in the interest of time, because I'm running out, skip forward on this, but basically to say there are 3 different ways that we use the data to do this. We can either look at historical rates, so we can look at comparing rates from last year for a cohort compared to this year and see if there's a difference. We can look at comparing, I'm going to skip through. We can look at comparing a self, so it's your vaccine and you're looking at your adverse event in a period of time following it, and then we can look at, you know, comparison window, whether or not you've had that event, and do a statistical comparison there. Or we can use a matched control, which is we can compare your vaccination experience with someone else that's been matched on sort of key demographics and try and work out if there's a difference between those two groups. So what I was hoping to get out today, so data linkage that we've developed during COVID has increased our capacity to monitor these things and hopefully give more confidence that we are sort of closely monitoring vaccine safety. What I do want as my primary thing to come from this though is that we don't cover events that are detected in general practice, and we still rely on that WAVs and that passive reporting system. So although I think this is a good addendum to that, it still relies on immunisation providers to be picking up these events and reporting them to us so we can encapsulate those as part of our system. In the last couple of minutes that I've got, I just wanted to move on and talk a little bit more about vaccine effectiveness and why that's important. So vaccine efficacy, vaccine effectiveness, we sort of tend to use them interchangeably sometimes, but I guess just to clarify the difference between those two. When we're thinking about vaccine efficacy, the degree to which a vaccine prevents disease and possibly transmission under ideal and controlled circumstances. So when the vaccines, particularly COVID, were first released, we would have heard a lot about the vaccine efficacy being very high in those clinical trials. What we then need to do is look at vaccine effectiveness, which is how well it actually performs in the real world. So when we do start giving this to populations outside of those sort of really controlled clinical trials, is it working as well as we thought it was initially? Limitations are that it requires a lot of people. So this has been a real struggle for us in the past in WA to get the sample sizes to do this, and we need to know people's vaccination status. We need to know whether or not they developed the disease or not. But we have been able to do this in WA thanks to the linked data system, and then start to sort of drill down and look at how well the vaccines worked in our population. So very briefly, I think just on the methods for this one, we ended up linking about 400,000 people for this study, so PCR positive cases and PCR negative controls for COVID, linked them on key demographics we had in the system, and asked the question how well our COVID vaccine works at preventing transmission and against preventing serious disease. So one of the key findings, which we thought was quite interesting, so these are 2 graphs that are looking at vaccine effectiveness. This is by time since vaccination for people who've had a 3rd dose booster. The graph on the left-hand side here is looking at people who have had 3 doses of an mRNA, of Pfizer vaccine, so Pfizer, and the graph on the left is comparing people who had 3 mRNA, so Pfizer, with people who had had Astra, Pfizer. So the booster was actually a mixed schedule. And what we found here is you can see it follows the same trajectory, and it ends up after 120 days of similar vaccine effectiveness, so it does drop off quite rapidly. But for people who had a mixed dose, a heterologous schedule, the effectiveness was actually prolonged for a period of time. And we did some controlling for this, and we found it wasn't to do with people's behaviour or the age groups that were getting the vaccine, but it was a sort of a real signal. Finally, in my last 5 seconds, so what we need to do, I think, going forward, so thinking about our vaccine safety and data linkage, we want to incorporate all this stuff into our business as usual. So continue to do this using rapid cycle analysis for seasonal influenza vaccines, getting some timely estimates of VE and being able to get those out there to you guys to be able to use. And also looking at safety signals, as I say, for RSV, Shingrix, other newly introduced vaccines. So with that, I'll say thank you very much.
Thank you, and thank you for watching time. I'll ask from here so we can still see you. So should we pay healthcare workers, doctors to report adverse events? And so that validates the concerns of patients. And the second question, you might want to throw in, did you pick up the AstraZeneca side effects before anyone else? Do you think your signal was quick enough and was it working for you?
So I'll take the second one first. So I think because the system was being built as the pandemic was unfolding, unfortunately, we weren't early enough probably. So a lot of the things that we were doing was validating our system against safety signals that we were seeing in other countries. So particularly the Nordic countries have really good reporting systems. The plan is for then us to be able to have developed this during COVID and roll it forward and start using it prospectively. So we weren't first, I guess, in detecting some of these safety signals, but what we have been able to show is our system does work, I suppose, in able to prevent them. In terms of paying people to report adverse events, I feel that we should probably be reporting them because we should be reporting them because we want to have safety and confidence in vaccines. And as I mentioned, it is actually a requirement that people do so as well. So I would encourage everybody. I think there is potentially a perception that people don't want to hear about vaccine safety or that they don't want to be bothered by small or minor adverse events. I would actually say the opposite. I think everything should be reported. All the information you gives us helps. And even if it's to tell people that you may get a sore arm following your vaccine, for most people it will be not very serious and resolved. That is useful information, I think, for anyone to be able to give out.
Just before Peter asks his question, but if you paid the doctors and healthcare providers to do it, not only does it fund the time to do it, but it also, you can say to your consumer, well, we pay them to report the side effects, so we don't under-report them like the conspiracy theorists say, we actually over-report them. Isn't that better?
Well, I think that there is an argument to be had there. So I think my personal first preference would be to make it a lot easier for people to report things. So I would like to build things into practice software that makes it very straightforward and easy for people to report, I think, is the first one before I looked at funding it.
Thanks. And I guess I was just maybe trying to respond a bit to Rod's questions. I think WA did, through the WAV system, they report the first case of it that occurred in WA after, I think, 10,000 doses of vaccine had been administered. So it was sufficient to detect those early cases, but the data linkage was not yet available. I think the other thing I just sort of emphasise is that as part of this reporting, it is reviewed by a clinical group who then actually refer them to a safety adverse event clinic for further follow-up to provide advice on subsequent vaccination. So it's actually also a benefit of the patients to be reported so that they can get the expert advice, and if we're not sure, then we can go to our colleagues in other states to do it as well. So I think it's a really good system, and I would argue that this should be something that is taken on board by the ACDC, and then questions such as, is there an item number for reporting serious vaccine safety events, can be done on a national scale rather than expecting the states to do it, because I think that might be difficult to implement.
Yeah. I think the questions was anyone who's reporting it, so even if an institution has to spend time doing it, if the providers who were set up just to do it would be supported. I've got a question here. Can you comment on long COVID registry hosted by Emerge Australia and how health professionals know how to use it? Does that?
I can't, sorry, it's not within my area of expertise.
Okay, so no other questions. So I think we're done. Thank you very much. Oh, sorry. Yeah.
I was just interested, great presentation, about the inclusion of pharmacy in here rather than just GP, because I know in terms of immunisation I had my pertussis recently.
Yeah, so pharmacies are required to report to WABs as well, so through our passive system, but within our data linkage system specifically, any vaccines that are given are linked to any hospital event, so we would be picking up people who were recorded in pharmacy as well. We haven't looked into doing any, I suppose, further work to see how well things are being reported by different sectors, and I think I didn't mention at the beginning, but anyone working in paediatric immunisations I think is very au fait with vaccine safety reporting. Pharmacies, I think, because they've come on board to the vaccination space more recently, have probably got a really good introduction because they've come during a very busy time for adult immunisation. But I think understanding the pattern of reporting and making sure that people who aren't picking up vaccine adverse events know they should be would be something that I think we'd want to build into our feedback.
Great, thank you.
And a 15-second, I think it takes longer. Why do you think the homologous vaccines, AZ and mRNA, was better? It's an international experience, so it's good you picked it up. Any 20-second comment?
I knew I was going to get that question, and I'm not an immunologist, so I have to say about my answer. I always look at Peter Richmond to try and help me out with these things. I am not sure the exact precise answer to that question, but you can feel free to speak to Peter at morning tea. I'm sure he would love to answer that for you.